This is Dr. Paul Sangha, Langara College. This talk is the third in a series on COVID-19. I created this presentation primarily for my mid-baccalaureate nursing students, but available for anybody, of course. My first two talks were created in 2020 and 2021. They were about everything from the virology all the way through to the therapies used for COVID-19. As of those dates, they were reviews of the scientific and clinical literature up to those points. This talk is the follow-on. It's focused on what's commonly known as long COVID. We're going to be calling this post-COVID condition as per WHO recommendations. This is a huge clinical and medical challenge at the moment. Many people are infected. It's not fully understood what all the risks and pathophysiology involved in this are, but we're going to take a stab at reviewing at least what the current literature is on this. The outline, I'm going to be quite succinct, I hope, not too involved in a lot of the details, but at least to give you a feeling for the day, as well as cutting to the quick and talking about what are the primary mechanisms involved in the pathophysiology of persistent COVID, or as we're going to be calling it, post-COVID condition. So we'll talk about the COVID pathophysiology updates for acute and severe COVID-19. Then I'll get into the definitions and terminology of the condition we're talking about here, the estimated prevalence, clinical manifestations, and pathophysiology. And lastly, I'll end up talking about some risks and triggers as well as recommendations about exercise. So just focusing on acute and severe COVID-19, the key motivation here is to give a bit of a feeling for the day of the type of molecular detail that's been added to understanding some of the injury that occurs with COVID-19. I'm not going to go into all the details. I'm going to present some slides that are directly from the literature and which give a fairly up-to-date idea of what's being worked on and what it represents. What you can see in this slide, this is from Lammers and Hogmans from Nature Reviews. You can see a picture of the virus on the top, a representation of the virus. For those of you who are uninitiated into the virology, if you haven't looked at my other presentations or don't know about it, the virus is made up of a strand of RNA that carries the genes that are involved in transcribing the proteins that are used in the virus. It has a capsule, and it also has spikes that are sticking out, which give it a kind of a halo or a corona, which is what gives it its name, a coronavirus. The spike is made up of two significant proteins, the S1 and S2 protein. You can see on the next line down. The S2 and S1 protein are involved in binding onto the receptor of the target cell. Now, most of the target cells are endothelial cells. For those of you who don't know, endothelial cells are flat cells that line your vascular system and your whole cardiovascular system, including the heart, but including all the blood vessels in the body. They're epithelial cells, and some areas of the body have many of these receptors, these ACE2 receptors, and those are the areas that we find are most affected by this virus. Anyways, what you can see in the line B of this slide is that the two proteins, S1 and S2, are cleaved from one another by a protease, TMPRSS2, and that leads to the activation of the S2 domain. It leads to further processes involving the viral fusion into the cell and the deposition of the single-stranded RNA genome into the host cell. Now, once this happens, once the RNA, of course, gets into the cell, it leads to a process of viral replication. Essentially, the virus is going to hijack the cell's machinery in order to make new viruses. All these viruses are ultimately going to bud out of the cell, and as they do so, they're going to damage the membrane, cause leakage, and may even kill the cell. But you can see the level of detail that's being provided here. You can see that up to now we have an idea of a number of different mediators, different molecular entities which are involved in both providing the pathways for viral replication, but also for activating antiviral mechanisms of the cell and of the system. So I won't detail, I can't possibly spend this talk detailing all of these molecules, but you can see that there's quite a few things that have been identified. And this is from Lammers and Hogmans in Nature Reviews of 2022. In terms of understanding how clinical manifestations start to arise from severe, right now we're talking about severe, serious, acute COVID-19. Some of the things that happen that have been observed really early on involve the formation of a lot of clots. And the clots can be what we call very small clots, which are called microthrombi, or thrombi, which are just clots. Clots are formed when there's the need to stop blood flow, but also when there's the damage to cells, especially the endothelium and the underlying tissue is exposed. This is one of the things that will provoke a sudden clot. Problem with clots, problem with, I'll call them their technical name, which is thrombi. Problem with thrombi is that they do their job, they prevent loss of blood, but at the same time, they block blood vessels. They can also break off and form thromboemboli. They can flow to the lungs. It's one of the causes of sudden death. But that balance of thrombi and antithrombotic control is very key to regulating normal blood flow throughout the body. If this becomes dysregulated, if thrombi are formed and there's a failure of the antithrombus system to control it, then you end up with a system full of clots, and that will stop blood flowing, and it will lead to what's called DIC, which is disseminated intravascular coagulation, which leads to shock and death. And many patients with COVID-19 were hospitalized died of DIC and shock ultimately, but as a result of this kind of process that is shown here, which involves a few things. If you look at the left side, it shows platelets being involved, monocytes and neutrophils being activated as the virus is attacking the endothelium. Endothelial cells are being damaged, destroyed. When they are destroyed, platelets get activated because of the exposure of underlying collagen, and the coagulation system, the cell-free coagulation system, is also activated through the intrinsic and extrinsic pathways. So that really jumps into some technical things that my nursing students will understand, but if you're a member of the lay public, you may not. But essentially, the long and the short of it is that dysregulation of the thrombogenic process and the thrombolytic processes is really problematic, and it leads to many of the severe manifestations of COVID-19. So if we just summarize a couple of things that I've touched on here. Mechanisms of acute severe COVID involve direct viral toxicity, which is endothelial damage. That, of course, stimulates, through damage to the blood vessels, coagulation. Hypercoagulability is a fancy way of putting it. It's a overexuberant thrombus formation and microthrombus formation. And as I said, that ends up occluding blood vessels. The immune system can be dysregulated by this overabundance of stimulatory factors, such as through the macrophages, through the neutrophils, as well as inflammation, a hyperinflammatory state in which one of the problems is that the factors will lead to a displacement of fluid out of the vascular compartment into the extravascular compartment. And that, of course, it can lead to shock. An imbalance in the angiotensin system through the ACE2 receptor that's involved in the receptor of the virus. And that, depending on where the ACE2 receptor is found, it's found in many different tissues, endothelium, lung parenchyma, heart, kidneys, intestines. All of those will be damaged as a result of the binding. This is from Munipalli et al. And reference is shown here. A bit about the epidemiology, but also talking now about the terminology and definitions of persistent COVID-19, or as we call it, post-COVID condition, also known as long COVID. So lots of different terms, lots of different controversy about how to deal with defining what we mean when we talk about people who have not just resolved quickly COVID-19 and have gone on to have a very long-term illness. Let's get it right into it here. If we look at the epidemiology very roughly, but the global picture is up to the end of August of 2023, at least 770 million confirmed cases of COVID-19 and around 7 million deaths. Now, this is according to the WHO coronavirus dashboard, which means that these are the numbers that have been reported to the WHO from all the different nations. This is lower than the actual number. We know that because I think most people know that many people don't report to their physician if they get COVID-19. Many of you have had rapid tests. Okay, you're diagnosed, you know what to do, but you don't necessarily report it to your physician. If you don't report it to the physician, it doesn't get reported in the data, it doesn't get reported to the WHO. So if you think about this world over, where people don't have physicians, where people are remote, where people are living in poor circumstances, whatever the case, we have a very significant underreporting scenario, as you would with any massive epidemic. Any epidemic of this scale is very complicated to get the numbers, epidemiological numbers. Similarly with death, there's always been an ongoing challenge of death certificates, of people reporting properly cause of death. Many deaths don't get a proper death certificate worldwide. That's been an ongoing problem even before COVID-19. So the underreporting not only is on confirmed cases of COVID-19, but also on deaths. What is the actual number? People have grappled with it. I won't try to take a stab at it, but I would just say that, say you can call it at least 1 billion confirmed cases, at least 7 million deaths, but probably many more. So of all those people, how many people are into ongoing COVID symptoms? Well, the problem is that there's such a variability in how people are affected by ongoing COVID-19. So it could be variability in severity, variability in what type of symptoms they have. There's over 200 symptoms have been reported. How long they have it for, we have to define all these things in order to get a clinical definition, in order to be able to say, oh, this is the post-COVID condition, or it's not, it's just a regular. So just in terms of terminology, you know, I've been using some of these terms, but most people are aware of the media literature, in which long COVID is probably the most common term that's used, but long haul COVID, post-acute syndrome, this is in the medical literature, persistent COVID-19 syndrome, post-acute sequelae of COVID-19, chronic COVID-19. These are all found in the literature, and they all refer to roughly the same thing, but depending on how you define it. So the WHO, starting in 2021, has tried to grapple with this. The significance of the WHO, of course, is that it is an attempt of nations to come to agreement on defining clinical conditions. And you know, you can look in the ICP-10, the International Compendium of ICD of diseases, which tries to define every definable disease. But in terms of COVID-19, ongoing COVID-19, we've called it post-COVID condition. So what is an estimate of the prevalence? Well, 65 million, 10 to 20% of all cases, which is much more than that, possibly up to 80% of COVID cases have progressed to PCC, post-COVID condition, but with various degrees of severity and with various mix of symptoms, of the 200 or so symptoms that have been reported. Getting right to pathophysiology of post-COVID condition. So there's, I'll try to give you an idea of the clustering of conditions and then look at the pathophysiology. The key pathophysiology probably centers around 4 or 5 mechanisms. So then I've talked about some of them already with respect to acute and severe COVID-19. So if you look at for post-COVID condition, long COVID, most common reported symptoms include fatigue, dyspnea that lasts for months. But other persistent symptoms that are very commonly reported include cognitive, so neurological symptoms. People complain of brain fog, loss of memory, but also other neurological things such as loss of smell and taste. Other conditions, cardiovascular and pulmonary, chest pains, palpitations, musculoskeletal, joint pain and myalgia, headache, GI, diarrhea, reduced exercise capacity, and fatigue, as I said, is at the top of the list there. So that gives you a rough idea of some of the things. You can group these according to their temporal pattern and causal association. Fernandez de la Peñas and et al. Have talked about the exacerbation of baseline conditions in patients, especially around diabetes, but other conditions as well, set the stage for worsened recovery from COVID-19. So they talk about exacerbated symptoms as opposed to delayed onset symptoms, which may come about immunologically, I will mention, as well as other conditions which just don't go away, which are persistent. So this is one way of talking about trying to group the symptoms, and also it gives some hints as to possible mechanisms, pathophysiological mechanisms underlying those symptoms. Or you can talk about just the time after the acute infection. Davis et al. Summarizes this in Lancet eClinical Medicine. They talk about cluster 1, cluster 2, and cluster 3 symptoms. Cluster 1 symptoms being the first ones that happen in the first 3 weeks after the acute phase: loss of appetite, sore throat, dry fever, dry cough, fever, and runny nose. Cluster 2 symptoms, constant around the second months: tachycardia, syncope, myalgia, headache, dyspnea, fatigue. Cluster 3 symptoms, dermatological, autoimmune, allergies, brain fog, memory issues. These happen later after the second month, according to their categorization of them. So you can, I'm just pointing these out as different ways that people have tried to rationalize and also get an idea of what is the underlying pathophysiology by the pattern or etiology of the condition, so far as it is known at the time. So, you know, Honhurst and others have looked at clinical aftermaths of COVID-19 and taken the approach of they've called it subacute ongoing COVID-19. You can see after 4 weeks, you know, fatigue, dyspnea, anxiety, concentration, headache. And after 12 weeks, fatigue, sleep disturbance, dyspnea, agnosia, and headache. These are somewhat in agreement with the previous, but they're just grouped differently and named differently, as you can see: subacute and post-COVID condition syndrome. So I'm going to be looking at, just showing some different slides from different authors that are reviewing the pathophysiology here. So please take it in that spirit. Different people have emphasized different aspects of this, but in this paper in Transit Immunology by Peluso and Deeks, they try to get some kind of idea of what is going on in terms of mechanisms by looking at the predictors and then looking at the symptoms. So for an acute COVID-19 patient, probably a minority of patients go to a full recovery right away. Other ones will involve varying degrees of long COVID, or as we call it, post-COVID condition. They're calling it long COVID, but same thing basically. And the predictors for their symptoms and for the degree of post-COVID condition are demographic factors such as age and sex. We know that older people are more susceptible. We know that older men are more susceptible, whereas in the under 55 age group, it's women that seem to predominate. If they have medical comorbidities such as obesity, asthma, diabetes, and probably a longer list, but in the main, these ones will set the stage for a higher risk. Acute COVID-19 severity and viral load, well, this makes sense. How severe the original infection was is going to play a big role. Social determinants, like poverty, crowding, vaccination status, whether the person has been vaccinated and how many times. And if you look at the types of things that are identified as possible mechanisms in this paper, they look at the possible persistence of viral antigen has not gotten cleared from the system. So you've got proteins or peptides which remain in the system, sequestered, embedded. Systemic and tissue-specific inflammation. As we've talked about, the inflammation system can get dysregulated and can become overexuberant, leading to ongoing issues. Immunological, including the observation that many people end up with persistent herpes virus reactivations. Epstein-Barr virus has been identified in a lot of people. Varicella zoster and herpes simplex. Dysbiosis, which is the imbalance of flora, loss of normal bacterial populations in the gut. Microvascular dysfunction, of course, we've talked about coagulation issues and also talked about how the vascular system can become damaged. And lastly, SARS-CoV-2 specific immune responses, that antibodies, this may be a delayed response. We know that this happens in a number of other disorders where you get an autoimmune type condition that arises because of cross-reactive antibodies that are raised against the virus. So another look at this is, immune dysregulation, microbiota dysbiosis, same thing I've just talked about, autoimmunity and immune priming, blood clotting and endothelial abnormalities. And then the reason I put this in here is because, of course, these authors, Davis et al., have mentioned dysfunctional neurological signaling, understanding how dysautonomia, which is common in a lot of people, a loss of autonomic tone and vagal tone, is one of the neurological issues that's quite common. You can see also here they've talked about, so proposed mechanisms include dysregulation of the immune system, microbiota, autoimmunity, clotting, endothelial abnormality, dysfunctional neurological signaling, and you also notice some of the herpes viruses that I mentioned are involved, are noted here, EBV, HHV6. Davis et al. In the Nature Reviews have tried to sort this out in terms of symptoms in the red and pathologies in the blue. If you look at the tissues, you get the pathologies, as opposed to the symptoms you see in the patient. So, for example, chest pain and palpitations because of cardiac impairment myocarditis. And, in terms of the lungs, cough and dyspnea, the observation is on spirometry, abnormal gas exchange, and by looking at blood gases, I should say. And then the pancreas, pancreatic abnormalities, diabetes, pancreas injury on the pathology side, immune system, autoimmune, signs of autoimmune antibodies, and monocyte activation, mast cell activation, I should say, gastrointestinal, abdominal, and nausea from gut dysbiosis, loss of flora, as I mentioned. And on the neurological side, a little more complicated, cognitive fatigue, disordered sleep, memory loss, these are all symptoms. And then the pathology involves, as I said, dysautonomia, chronic fatigue syndrome, which, fibromyalgia, this is neurological, not entirely understood, of course. Neuroinflammation, reduced cerebral blood flow, neuropathy, kidney spleen, blood vessels, coagulopathy, DVT, endothelial dysfunction, microangiopathy, microthromby, pulmonary embolism. So, and then on the reproductive system side, both male and female issues. So these are the pathologies that have been found up to this point, in 2023 in the blue. So trying to put the pathological findings, the tissue findings, the clinical findings, put these together with the symptoms that are reported is, of course, the job of the pathophysiologist. And you can get a little closer to that in this way of looking at the pathophysiology and mechanism of long COVID, a comprehensive review, which was published online in 2022. It shows a little bit more detail about how the cardiovascular system is affected with microthrombosis, inflammation, activated nets for inflammation, microangiopathy, alteration of heart contractility, probably because of myocarditis, fibrosis, conduction abnormalities. And what these things lead to is shown here on the cardiovascular side. The pulmonary system changes include damage to the autonomic nervous system and fibrotic remodeling after the ground glass kind of appearance that occurs in severe COVID. You get fibrosis, and how much that clears has been observed, but to be determined, I guess. Dyspnea, oxygen diffusion, gas exchange, and cough. So just focusing for a moment on the neurological side, which is one of the areas that is more complicated in a way, but we know that there's a pretty good idea that inflammation of the brain and nervous system, the central nervous system and peripheral nervous system are what's going on. You get microglial activation, coagulation, microthrombosis, vasculopathy, oxidative stress, autoimmunity, and metabolic disorders, all signs of being involved in different studies. And on the peripheral side, vasculopathy, oxidative stress, autoimmunity, changes to the angiotensin system, and those are, can manifest as pain. If you look at how severe the illness is on the acute side, it correlates with how much neurological damage happens, and then presumably ends up with some degree of neurological effects from, everything from peripheral to psychiatric disorders to chronic fatigue. I'm running a little roughshod over those slides, but bear with me. I want to be very summary in this talk. It's quite a bit of things to talk about. So relapses and symptomatic exacerbations. I think the main point to note here is that knowing the baseline health of the patient and also the degree of manifestations that they had during the acute phase of the disease is going to be very important in determining the degree of post-COVID conditions. So for a patient who suffered from acute respiratory distress syndrome as a result of COVID-19, they're going to be in rough shape. That's going to lead to long-term recovery. It's also going to lead to more activation of the coagulation system, microthromby, and then DIC potentially. Immune dysregulation, how much virus and how much viral antigens persist in the system is probably the basis of it, possibly cross-reactivity of antigens as well, the usual mechanisms that are suspected in autoimmunity of any sort. But this has been observed that many patients have autoimmunity that appears in post-COVID condition. So just a summary of the major mechanisms. That's an attempt here anyways in Iwasaki and Petrino's paper. It's in Lancet Infectious Diseases. Just so if you were to remember anything about how the symptoms of post-COVID condition are coming about, probably we can identify just about 5 things, some of them more obvious than others. The first one being that there's a reservoir of antigen or viruses that is not cleared from the system. Fairly straightforward. Second one is that there's autoimmunity, which is going to, of course, be somewhat connected. Autoimmunity may be set up as a result of antigen being left behind. Virus reactivation, such as herpes viruses being reactivated that are latent as a result of immune changes as a result of damage. Last one is about tissue damage and dysfunction as a result of direct tropism of the virus. So that's pretty straightforward. The fifth one, I said 5, not 4. The fifth one involves inflammation, and we'll deal with it separately. It's an important one. So the boxes here show, some of the details of these issues with vascular damage, microclots, platelet activation, hormonal imbalance, and mitochondrial dysfunction as possible root of the fatigue leads to these manifestations. And shown on the very right side is, some of the challenges to clinical assessment that are needed, including identification of biomarkers that are reliable for identifying persistent COVID, post-COVID condition, and lastly, randomized clinical trials to test prevention and treatment, including antivirals, including anticoagulants, immunomodulators, etc. So key thing I wanted to say is, of course, for many patients, the issue is going to be one of inflammation. As I said, with thrombosis and antithrombosis, the fibrinolysis, that's one key issue, especially in the acute, severe COVID-19. But in the long term, one of the things that is always a challenge is that the inflammation system becomes dysregulated. It becomes out of balance. It is going to be very important to understanding the degree of viral clearance, as well as how secondary infections occur, which may exacerbate or make worse the symptoms, of course, and how fast recovery occurs. So picture, inflammation, anti-inflammatory response, it has to be in balance. If it gets out of balance, you get into a complicated and longer recovery for the patient. Last point here is about this is I just thought this was useful in terms of looking at some clinical responses to people with post-COVID condition. Some of the questions that come up or have come up quite a bit is whether people should exercise as a result of after COVID, or whether they should rest, whether exercise exacerbates conditions. There's a lot of different findings on this. The answer probably depends on a lot of different factors, including how fit the patient was before, their age or sex, severity of the acute infection, and their immunology. So there's kind of too many things to really consider here to make a generalization about it. Some people are going to respond to jumping into exercise at the appropriate time, and others may find that it takes them downhill. When you look at this, it's kind of a nice review of, looking at some of the major things that are happening here, and then whether exercise is going to be complicating or improving the condition. This is from Honhorst et al. What are the, what kind of sequelae of viral toxicity does a person have? Things like pulmonary fibrosis or myocarditis or kidney damage. Those things are going to make returning to exercise more complicated, of course. Whether the immune system is patent after and the inflammation system is working properly, if it's still out of whack, it may make things very complicated, of course. Whether the blood vessels and vasculature is returned to normal, whether there's normal clotting and fibrinolysis going on. Metabolic dysregulation, I mentioned the mitochondria, but there's metabolic changes that have been observed. Shift towards anaerobic glycolysis, possibly because of mitochondria being compromised, especially in the brain. Whether there are pathogens, viral antigens or viruses or other viruses such as herpes viruses that are being reactivated, whether there's autoimmunity, whether there's changes in blood cells as a result of the infection. All of these things are going to, affect how well someone's able to tolerate exercise and whether or not it's going to be a problem that'll compromise them more than just resting. So, there's been some writing about trying to come up with recommendations with different criteria: resting heart rate, blood pressure, O2 sat. Barker Davies added a 3-week safety period after cessation of sore throat, etc. If patients have complications of myocarditis or pneumonia, they are not recommended to engage in exercise until they're completely clear.